today and tell you a little bit about the difference and the options in hospice and palliative care. As mentioned, I have spent 30 plus years in hospice care with Livingston Memorial Visiting Nurse Association, helping them create their first hospice program. And we started in 1986 and we continue now. I've been the medical director and am far and away too comfortable talking about dying, and will do my best to help you understand and bring it to some hopeful, simplistic concepts for you. Please feel free to ask any questions, and I'll do my best to answer them when we're done. I'm going to use PowerPoint because that helps me visually show you so you don't have to stare at me the whole time. And so I'm going to turn those on and share my screen, and hopefully you can see that. Are we good? Everybody can see my slides there?
Yes, good to go.
Good. So that's my name, lanyard, like one of those lanyards around your neck, dial like dial the telephone. And I continue to serve as Livingston Memorial Visiting Nurse Association's medical director and oversee all their hospice care. Again, we started in '86, so we're on 37 years this year. And the lack of creative title, we're going to talk about hospice and palliative care. These two words tend to be confused, and in many ways they are similar, but America has created very specialized programs that make it important that people understand the differences between these two concepts. And I'm sticking to America. Death and dying and the options available across the world vary quite a bit. And I hope you appreciate that there are tremendous cultural differences in the concepts of death and in how societies manage and deal in that. Many of my comments will spill over into other Western medical societies, but I'm certainly not the most fluent on all the cultural aspects across the world, but I feel very confident in telling you what death and dying and hospice and palliative care are like in America. I start, and you may have read one of the promos about this, with the idea that I personally believe dying in 2023 is the hardest it's ever been in the society of humans. Prior to maybe 100 years ago, death was, if you will, simple. People died. There wasn't a complexity to the dying process because we knew very little about medical care and what to do and how to help people. Now, today, we know a lot, and modern medicine has created very complicated dying processes for many people. And again, I think dying in 2023 is extremely difficult. Usually when I do this talk in a group room, I say, at this point, go ahead, somebody in this room, try dying. And what I can tell you will happen is that the remainder of people in the room will do everything they can possibly do to make sure that doesn't happen. And they will be contacting people on their phones. Others will be starting to pump on your chest and blow into your mouth. And we will do whatever it takes to try to keep you alive. And an ambulance will come, pick you up, sweep you off to the hospital, where in the emergency room, they will do far and away the most advanced medical treatment possible and try to keep you alive. So dying is extremely difficult. And why is that? And I want to take you back and talk a little bit about the history of this country and dying in this country, and why it is so difficult today. When the country started, as the Americas as we know it, and pilgrims came over from Europe, certainly people were dying. That journey was very arduous. They landed in our lands in a very difficult seasons, and people died. Their medical care was rudimentary, and there wasn't much that we could do. If you extend this back to that time frame, you'll see it didn't change much from the start of America through to the 1800s. People, on the average, lived to be under the age of 40. They died mostly of infectious diseases because we didn't understand those. We didn't have good hygiene. There was certainly aspects of food and sanitation that were involved in causing people to die. But infectious diseases, antibiotics, vaccinations didn't become part of our cultural heritage until much, much later. And throughout the eras, you can see from 1850, I'll go back here to 2010, even 2020, the average age of death has gone up and up and up. We're now near 80 degrees. Near the age of 80 in which most people are dying. You might have heard that switched a little bit in the last years as COVID hit, and our average age of death has dropped into the high 70s. Averages tend to do that as things change, but it's important to understand that today most people expect to live a long life, and they expect to live a life into their 80s. In fact, I think if you queried people, they would think they're going to live into their 90s to 100. If you go back to 1850, which is when that particular slide I showed you before was timed, we were just entering into a major civil war in the United States. And what happened during the Civil War era is certainly each other of us were both shooting other people as well as exploding bombs near other people with cannons. And people died from direct hits of those injuries. But the vast majority of people during the Civil War era actually died of infections. They died of infections from bullet wounds in their extremities. They died from infections from shrapnel, from bombs in their extremities, or from the harsh conditions and getting pneumonia during that time. And we had no antibiotics, no understanding well of infectious diseases. A lot of amputations were done to try to preserve someone's life as the limbs were becoming infected. Death happened at all ages. This is Abraham Lincoln's 3 of his 4 children. The youngest died at age 4 from pulmonary tuberculosis. The middle child died at age 11 from typhoid. His oldest child died at age 18 from pulmonary tuberculosis. His oldest child actually lived on into his 40s. But 3 of his 4 children died from what was very common during that time frame, some type of infectious disease. That was our history in America of how important infections were. In fact, you will know that Lincoln himself at the age of 56 was shot in the back of the head at Ford's Theater, an injury which even today, probably we couldn't have saved him. But 4 presidents later, Garfield, who was the president in 1881, was also assassinated. He was shot in the back, and he died 3 months after that gunshot wound. Not because the gunshot wound hit any vital organ, but because he developed abdominal infections because of that particular wound. And he died from infectious disease. World War I, fast forwarding from the Civil War area to World War I, we still had no antibiotics. Our hospital, our medical care looked different, but we still had significant deaths from infections. It was still an era where we did not understand that problem. World War II forward is the time frame which I will then talk further about as the era of modern medicine. And why I show you this and why I talk about this is to understand that it was at this point forward that we altered the patterns of death of our people in our country. Now we understood much better about infections. We understood how to develop vaccines. From the time frame of World War II forward, we had antibiotics. Here's a thanks to penicillin, he will come home slide. And this was part of the World War II efforts where we developed antibiotics that could keep alive a soldier from one of those terrible wounds. And antibiotics and vaccines played a major role post World War II in the changes of our lifespans. Interestingly enough, we learned how to do CPR in 1960. So about 10 to 15 years post World War II. Many people think, oh my gosh, I thought we knew how to do CPR way before that. No, the concept of actually cardiopulmonary resuscitation, of pumping on someone's chest or breathing into their mouth to try to keep them alive, was developed in 1960. Our first ICU in America was developed in 1962. So the concepts of intensive medical care, keeping people alive, using equipment to breathe for them or pump on their chests, all was a post-World War II phenomenon. Then modern surgery with an understanding of how to prevent infections from happening, how to do transplantations with our first successful kidney transplant in 1964, heart transplant soon thereafter, 1967, this first successful pancreas transplant in the 1980s, has made it such that we now anticipate that modern medicine can virtually keep us alive forever. I use a dying pendulum to help us understand that. On this side of the pendulum is where we live. Medicine can do almost everything. In fact, there are people amongst us all who think dying could be avoided, that they shouldn't need to die or have to die. There are people who talk about the reason I'm dying is because medicine has failed me, that medicine should have been able to keep me alive longer. They made the diagnosis too late. They didn't give me the right therapies. I should be able to live longer. When I and our hospice team see families and patients, we're frequently running into individuals who are in their 90s who are dying, and the family is shocked. Oh, geez, dad's 92. We are so surprised he's dying. And you know, in my glib times, not in with patients, I'll say, really, what did you think was going to happen? We will die, and it will come to every one of us. And you're right, modern medicine is amazing, but death is not avoidable. And the other side of this pendulum is what I talked about back in the early 1900s or so, or any time before that, where really modern medicine didn't exist and we couldn't do very much. And Lincoln lost his kids, and that wasn't a surprise to the people in that era. People died young, and death was a much more common and acceptable situation. I'm glad we live further to the right. I'm glad that we live more where medicine can do things for people. I would hope that there's a middle to this pendulum where modern medicine can do everything that's good for people help people along the way so that they can live as full a life as they can, but also understand that dying isn't avoidable, and develop and create programs where dying is supported, where families are supported, and it's much more comfortable. I think that middle is where hospice and palliative care try to drive to. But to be honest, we still sit way over here. We still sit in an era in which people are on this side of the pendulum. I was speaking to a friend of mine yesterday who said he had a good friend of his that was now going to fly to Germany to get an experimental treatment for metastatic prostate cancer that might allow him to live another 3 months beyond what his current life expectancy is. And that's kind of what happens. Medicine can do a lot, and people want to strive to get that. People are not comfortable with dying. People are not comfortable with the idea of avoiding everything that medicine can do. This is my picture of the era in which the doctor sat at the bedside. The family was distraught, but they were going to lose this child because medicine couldn't do anything. The era today is much more every tube and every orifice, and the death wanting to know when do I get into here? How do I get into here? How does this work? And how do we help people understand and be more comfortable to find the right timing for them and their family as they try to navigate medical care and their death? We've gone from an era where infections or even heart attacks took someone to an era in which people are dying on much more of a chronic diseases. Certainly there are acute deaths. There are people who acutely die. They have a huge heart attack and they go. But the vast majority of people with heart attacks these days are whisked off to the hospital. They're getting procedures on their heart to revascularize the heart tissue, and they're kept alive longer and longer because medicine can do that. They're kept alive with more heart difficulty, with more heart failure or lung failure. They're kept alive with cancers that we're treating and treating and treating, only to have a death once those treatments fail, once those treatments come to an end. And so death moves from a quick acute thing to a much more anticipated chronic process. The patients in these begin as very independent and capable people. But as those diseases progress and as our treatments come in, people start to lose that independence and they grow more frail and they lose ability to do their daily functions. They start to have needs for more caregivers and more nursing support. If you look in our society right now, one of our biggest problems is having sufficient caregivers for people, because people are kept alive with their serious diseases longer and longer and longer, and there aren't caregivers to help take care of them. And it's a big struggle in what I see going on in the senior population in our community. At some point, there is the recognition or the discussion that this disease process, this chronic loss of abilities based on whatever disease you have, makes you terminal and you die. That's kind of the progression of what most of us will go through as we get older and develop whatever disease we get. At some point, comfort care becomes important in this. So whatever your illness is, whatever anyone's illness is, whether it's heart failure, that's the CHF, or COPD, chronic lung disease, terrible diabetes, renal disease, renal failure, even post-transplant renal failure, whatever type of malignancy people have that they're getting ongoing treatments for, heart disease, liver cirrhosis, infections like HIV, those illnesses can be treated, but they continue to progress. And at some point, you will gradually lose function and find yourself in a state of being in need of caregivers until a terminal phase in your death. That's dying in America today. That's no longer boom up and die. It's modern medicine taking over your illnesses, helping you manage those so that you can live longer, but recognize that that has an end to it. And that end looks more like this than you up and dying very quickly. It is a process by which you start to lose function until you become terminal. When does that conversation start? There's a wonderful video, if you haven't had the opportunity to see it, called Consider the Conversation. And it's a video about talking about your death or your loved one's death, and how is it going to be? What's it going to be like? And when do you know it's happening? I can tell you this. In modern medicine, if you get a diagnosis of terrible cancer or terrible lung disease or terrible heart disease, there is no discussion about your dying at the beginning of that illness. Every doctor will say, you got terrible heart disease. You're going to need surgery. We're going to need to put your vessels back together. You're going to need a bunch of medicines. We're going to be able to do this. You've got to get these sets of tests. If you get a very bad cancer diagnosis, the doctor isn't going to say to you, you're going to die. They're going to say, you're going to need these tests. We're going to see these specialists. You're going to start radiation. We're going to get you chemo. The conversation is not about dying. It's about how medicine is going to do its best to keep you alive longer. At some point in that, it becomes hypothetical to you or your family of, could this be the illness that I die from? It's still not a very open conversation, but it's certainly in the back of individuals' minds, until it becomes more obvious that death is now possible from this disease. In fact, it's probable, and now conversation becomes more, until it becomes inevitable. And the discussion somewhere along here starts. And that's when the idea of consider the conversation comes in, of at what time frame should you consider that conversation. I hope what you appreciate is we're really good at this. We love life. All of us love life. We hold on to life. We define our lives by our families, our interactions, our friends, and what we're capable of doing. And we're a little afraid of this death thing because we're not quite sure what it is. And we haven't had a whole lot of information about what death means. There's lots of talk about people who believe they've stepped into death and then come back and been able to tell us that it isn't scary, that it is wonderful, and it's soft, and it's butterflies, and it's lights, and you feel like you're floating. And but we really don't know what that is. But what we don't like is this. We don't like the concept that we're dying, that we're going to make a transition, that it's a scary thing for people to talk about. It's hard to accept that we're on this arrow. I can tell you, all of us will be on this arrow. That's just who we are. That's the process. What modern medicine has done is create two programs, two terminologies to help in this. And I want to differentiate them and help you understand them. The beginning is the word hospice. Hospice is an old word. It's a word that dates back to the Middle Ages easily, because all of the hospitals that were originally created for people in the Middle Ages were called hospices. And that's because the vast majority of people who showed up at them not expecting treatment, but care. care because they were dying. And so hospice and hospital were a synonymous term during that era. But in the 1960s, this woman, whose name is Dame Cicely Saunders, was working in the London area and dealing with the British National Health Service. And she said, again, this is the 1960s. This is antibiotics, vaccines, starting of ICUs, starting of aggressive medical care. And she said, we need to create something for people who are dying, because what I see happening, she saw happening in this era, was death was being pushed away and not talked about. And death was not something that medicine would accept or help take care of. So she felt that was important, and she created the first medical model of a hospice care in the modern medical era. And that happened in the 1960s in London. The name of her hospice program was St. Christopher's. And in 1968, she came to the United States, went to a group in Yale in New Haven, Connecticut, and gave a lecture about the hospice program she had created. And that began the movement of hospice in the United States. Hospice is a concept, a program that provides medical and emotional care for people who are dying. The care that hospice provides really focuses on relieving people's symptoms, supporting patients and their families when that person is terminally ill. And the lingo picked up to a life expectancy of 6 months or less. The 6 months is a very arbitrary time frame. But the logic is someone who has a terminal disease, and this program created in Britain, but has been developed further in the United States, helps relieve symptoms and support patients and families. With the goal, the emphasis is, how do you make this person comfortable? It's not something we can cure any longer, whatever that illness is. And we want to have a peaceful and meaningful dying experience for that person. We want to support the person and their family as they're dying of whatever illness they have. 1968, when Cicely Saunders came to America and gave her presentation, and from that time frame over the next 14, 15 years, it was very counter medical culture to be hospice care. It was in the community, it was nursing based, it involved a lot of the religious community. Physicians were rarely involved. Physicians in 1968 were all about setting up the ICUs, developing new cancer therapies, transplanting organs, and the concept that you would allow someone to die was not acceptable. I was in medical school a decade later, about the late 70s, and still in medical school, the talk in the late 70s was that you needed to do everything you could possibly do to keep somebody alive. In fact, we had meetings at the end of our weeks that talked about what errors did we make that allowed this person to die. Death was unacceptable. Death was to be avoided. Death was to be learned from so it didn't happen to the next person. And so between 1968 and 1982, the concept of hospice was percolating in our communities, but was very much not involved in our medical community. In the early 80s, Medicare, based upon the push from many of our legislators because of what was happening in their communities, decided that they would create and look at a way that Medicare could actually pay for hospice care. And the belief from the community-based hospices was, we don't really have access to the funds to help people. We don't have enough equipment and supplies. The patient doesn't have the medicines they need. We're fighting too much the medical community. If Medicare picked it up, it would be a much more acceptable process. And so in 1982, Medicare began a demonstration project of would hospice work. And certainly by 85, 86, they made the decision to fully fund this and develop this, which led to a much wider acceptance of what hospice was. If you remember back, I mentioned that the first medical hospice under Medicare certification in Ventura County was Livingston Hospice, and I was the medical director, so that time frame is rich in my mind. One of the things Medicare said was that this should be a team effort, that you had at the top, the medical director, myself, who would oversee, and the patient's primary doctor here who could still be involved. You might involve nurse practitioners. So this was the physician side of this. Nursing was a key to all of this care. There were social workers and volunteers, chaplains, grief support, caregivers as part of hospice to do bathing. And this was the interdisciplinary team or the multidisciplinary team that Medicare required to be part of every hospice program in America. And the care of our patients and family is under this team's care, and that's how it's structured. The key points of what Medicare created, it's important to know that although I've said over and over again, this was a Medicare-driven situation over the years, every single payer of medical care uses these guidelines. So if your coverage comes from Blue Cross, they use this. If you're part of a senior health plan with Kaiser, they use this. So the guidelines created by Medicare are universal in the care of patients. So what I tell you here applies to all patients because Medicare, the government, wrote the rules. And basically, they expected the prognosis to be 6 months or less. Now, as I mentioned, that's a loose expectation these days because we all recognize no one can tell you. But they do structure the program around that time frame. And so they talk of 2 90-day periods of hospice care, followed by an unlimited number of 60-day extensions. So you can live for 3 years on hospice care, but you have to be able to work with Medicare and document and show 2 90-day periods and ongoing 60-day periods. And those mean particular documents sent to Medicare at the end of every 60 days on how the person's doing, or again, sent to Blue Cross or whoever the payer is. And that's the structure, 2 90 days and an unlimited number of 60-day extensions. Your hospital doctor structured benefits are all now turned to provide your hospice care. So in the Medicare world, that's Part A. Part A benefits are all shifted over to provide hospice care. If you're part of any other health plan, Kaiser, Blue Cross, any Health Net, any of the named plans, they take your current hospital benefits and shift it to pay for your hospice care. The payments for hospice care are to cover all the staff that you need whenever you need them. So they cover the doctor care, the nursing care, the chaplain care, the social work care, the CNA care, the volunteers. All of that comes from those payments. The payments cover all the equipment that you would need. So a hospital bed or a wheelchair or oxygen. They cover all the medications that you would need. They cover respite care for your family. So there's a time frame which, or caregiver, where respite care can be put in from the payments from Medicare. If you need to go into the hospital because the hospice program cannot manage your symptoms, that's paid for under this program. They also cover a year of bereavement under this program for your family. So payments from any payer, Medicare in particular, are converted to pay for hospice, and these are the things that those payments cover. Over the 1986 to current timeframe, the number of hospices across the country have grown and grown and grown, and the number of patients going into hospice care have grown. So current statistics, the most recent we have out published is in 2020. There were over 5,000 hospices in the United States. 1.7 million people each year go through hospice programs. And the average amount of time they spend on hospice care is 97 days. So when I showed you before the two 90-day periods, most people spend a little over 90 days in hospice care. Now, there are both extremes. There are people who barely make it a day or two on hospice care, or only survive long enough for hospice to get into the home and then they die. And there are people who have lived 2 years on hospice care. So the average is a little skewed because of those extremes, but somewhere in the neighborhood of 60 to 90 days is about what most people spend in hospice care. Who's eligible for hospice? It doesn't matter how old you are. It doesn't matter exactly who pays for your health care. In fact, because Livingston historically has been the nonprofit provider of both home health and hospice in Ventura County, we take care of people who have no paying source. It doesn't matter whether you're a US citizen or not, you can get access to hospice care. And it doesn't matter whether you believe you should be resuscitated or not, you can get access to hospice care. So hospice has very few limitations on who can be part of hospice care. But you must have a terminal diagnosis. You cannot enter hospice care in America without having a terminal diagnosis. Whoever your payer is, and even if you don't have a payer, the hospice program has to be able to document that you have a terminal diagnosis. And that terminal diagnosis is something that your doctor, as well as the medical director of hospice, have to review, look at, and agree upon that you are terminally ill and eligible to be into hospice care. I'll talk more about how we discuss that and what that agreement means. You should be seeking comfort care. It's not appropriate to say I have terrible heart disease and I'm waiting for a transplant and I'm set up and I'm going to have my transplant next week. And I want to come on hospice till I'm off next week. Hospice care is designed for people who are not seeking further curative care. So it isn't to be given in between chemotherapy regimens or while you're still on major chemotherapy. It isn't for individuals who are ongoing getting treatment for their diseases. It's that those treatments have failed. Those treatments are no longer helpful to the person, and you're really seeking comfort care. The last criteria that's really important is that you should have a caregiver. Medicare or none of the insurance companies or no hospice program wants to take care of you and help you die peacefully and comfortably unless there's someone around you who's helping. Because hospice isn't a program that's going to come in and stay there with you. It's a program that's really intermittent into your home and you need someone with you. That could be a paid someone, or that could be that you have moved physically into a residential care or a skilled nursing facility and they become your caregivers. But living at home alone and being part of hospice, you need to have a plan at least for as you decline, who is going to be there to help you and be a caregiver for you. So let's talk about each of these a little bit. The terminal diagnosis. There are three components to a terminal diagnosis. Medicine has struggled with these ever since hospice became part of a concept, was how do we know somebody is terminally ill? How can we make that prediction? Well, first, obviously, is what is the diagnosis? What's the main disease that's taking their life? And this is just a pie diagram of the major diseases that we see in hospice care. Cancers, Alzheimer's disease, or any of the dementias, serious terminal heart disease, bad lung disease, bad liver disease, bad kidney disease, strokes. Those are what is the major diagnosis taking this person's life. Occasionally we'll catch a physician who doesn't understand this and will say, well, the person's dying because they're old or they're failing to thrive. Well, Medicare won't accept that, or none of the payers will. You need a diagnosis. Are they failing to thrive because they've had strokes, or they've had heart disease that's terrible, or serious diabetes? There's some underlying medical condition that you can use. Number two is, what other diseases do they have? So you may have Alzheimer's disease that isn't very serious, but you get a very serious urinary tract infection, and now you're not functional at all. So your terminal disease will be Alzheimer's complicated by your urinary tract infection. So you can have a terminal diagnosis based upon an underlying disease complicated by another disease. And so we'll include that. But the third and most important piece is, how has those diseases, either the primary or the secondary, impacted your ability to do things? Because that's how you can be much more predictive. And that's where I focus people on, is hospice appropriate for me? Well, you might have a cancer that's spread, that you're getting chemotherapy, and you're doing just fine, and you're driving, and you're healthy, and that wouldn't be an appropriate time to enter hospice care. But once that cancer, even with the chemotherapy, has made it such that you can't get out of bed, that you can't swallow well, that you're now incontinent of urine and stool, that you can no longer bathe yourself or care for yourself, you've lost significant function. That disease has now led to the point where you are terminally ill. A standard hospice used functional scale is called the Palliative Performance Scale. And in fact, this is irregardless of your specific medical diagnosis. We want to know what the impact of that diagnosis has been on your illness and on your function. So if you look at this, 100% means you're fully functional. You can go to work, you have very little evidence of disease, you can take care of yourself, you eat normally, that's what intake means, you're fully conscious. You go down to 0, and that's death. Most people coming into hospice care are going to come into hospice care somewhere between 60 to 30%. 60% unable really to do a lot of work, significant disease, trouble walking, needing some assistance, can be eating normal. Alzheimer's patients really need to be at about 30%, totally bedbound, unable to do any activity, needing total care. Below 30 is minimal to sips of eating or mouth care only. So you can apply this functional evaluation to anyone with any disease, and it helps you understand, are they terminally ill? Now, someone with widely metastatic cancer who is no longer getting chemotherapy and is at 60% function is still highly likely to die in the next 6 months because they're not receiving any further therapy. So you can be at a higher level if your disease is serious and going to predictably progress very rapidly. On the other hand, if your disease is a slow disease, such as cirrhosis of the liver or terrible lung disease or Alzheimer's, as I mentioned, you should be nearer 40 or 30% functional level before we would say you're terminally ill in the next 6 months or so. Again, that or so is important because it doesn't have to be that specific. But that's the combination of what we look at: underlying diagnosis, other comorbid conditions, and your function. When we're talking about seeking comfort care and not curative care, one of the key aspects of that is further hospitalization or further ER use. I just spoke to a gentleman's family this week. He has very terrible Parkinson's disease. His PPS is at 30%. He's bedbound. He can't eat well. He's having trouble with all of his functional activities of daily living. He can't dress himself easily, etc. But his wife is absolutely adamant that if he were to develop a fever, she wants him back in the hospital on IV antibiotics, because she believes that he still is enjoying his life and she wants to see him continue to get aggressive medical care. Well, that doesn't make him eligible to be part of a hospice program, because you can't come into hospice if the plan is when something goes wrong, we're going to go back to the hospital. Now, there's a fine line there, because sometimes hospice can come in and work with the family for them to see and understand that that's not going to be a good situation. And we can come in, bring someone into hospice and work with them so that they don't seek hospital and ER care. But that is one of the cruxes that needs to really be looked at, is what does someone want for their future type of care? If there are therapies that you're planning on that are relating to your disease, those could be game changers for you not to be able to be in hospice. For example, you're coming into hospice because your kidneys are failing, but you still want to continue to get dialysis. Well, that doesn't work, because dialysis is designed so that you don't have kidney failure. And so you aren't terminally ill if you continue to get dialysis. Again, another fine line, but you got to really look at it. Transfusions. So you're kept alive because you need twice a week transfusions for a terrible disease of your bone marrow, and you still want to get those transfusions. Hospice will likely not be appropriate. You want to continue to get your ongoing chemotherapy or radiation therapy to try to eliminate this cancer. Hospice may not be appropriate. Now, all of those I've just talked about, even the hospital or ER use, all of that is advancing discussions as hospice is growing. And there are programs being developed to allow people to be part of a hospice program while they're still getting their dialysis or their blood transfusions. So I don't know what your particular insurance coverage is, but it could be that you're part of a program that would allow those things. And that's come up in the last year or two, is where some payers, and I'll use Kaiser as an example, has decided we will pay for ongoing support and hospice care. So there are people who could be part of hospice still getting those services. Obviously, if the therapy you're getting has nothing to do with why you're dying, you can continue all those. So if you're dying because of your cancer, but you have had ongoing dialysis, that's not a problem. You can continue to get dialysis and be part of hospice. If you have other diseases that you're treating, you have diabetes and you're getting insulin, or you want to get flu shots, or you want to have cataract surgery, All of that is unrelated to the reason you're dying. Those are all paid for by your coverage, and you can be part of hospice and get those. So all of that is a complicated little pieces of hospice care that I and anyone involved in hospice would be happy to look at anyone's particular situation to help them navigate this. Now I should speak for the last bit about palliative care. Palliative care started around 1990 in America. Between the decade of 1990 and 2000, we defined better what is it and what does it mean. It started to be promoted and grown in various places in our country. It was developed initially inside the hospice movement by people who said, you know, hospice scares people. Hospice is difficult for people. People aren't accessing hospice care both in numbers, but also in appropriate timing because they're unfamiliar with it. It's not simple. They don't like the word. They don't want to accept they're dying. And could we create another level of services that would help people? And we called those services palliative care. It was care that was designed to be focused on many of the things that we've already talked about: relief of symptoms, relief of pain, relief of nausea, relief of stress, whatever other symptoms came up because of your serious disease. But you didn't have to be terminally ill. This was not dependent upon the concept that you were dying of this disease. In fact, palliative care was designed to be given and be a part of an individual's care when they were dealing with serious illness, and given at the same time they were getting treatment for that illness. The goals of this care was to help people with their symptoms and discussions about where they were in the process of their terrible illnesses. That was the concept of palliative care. If you will, hospice is a small subset of palliative care as a whole. Palliative care goes beyond what hospice does. Hospice is for those people that are terminally ill, and palliative care are those people who have bad diseases that aren't terminally ill yet. Palliative care and hospice have a huge overlap, and that is the kind of care that they want to provide to people, optimizes their comfort, reduces their stress, provides for family support, emotional, spiritual support, helps better relieve symptoms. Palliative care, you receive at the same time you're getting curative treatment. Hospice care, terminally ill, less utilization of curative kinds of treatment. So we've talked about this, that there's an end of life expectancy built into the concept of hospice, clear guidelines utilized across the country on what Medicare sets, reimbursement from all payers to help pay for the medicines and equipment that people need. Curative therapies are questioned. Is this something that still should be part of hospice? And care for people is usually in their home or wherever they're living. Palliative care, since its creation, has been designed to be comfort care like hospice, but not terminally ill patients. There isn't an expectation that the person's going to die within 6 months or so. Now, what's interesting is there's no guidelines on how it's delivered, and that is because there is no straight reimbursement for palliative care. Medicare has not defined it. Medicare has not accepted it, has not created programs for it. The only payment for Medicare-related palliative care is to a palliative doctor, just like you were seeing an orthopedic surgeon or a gastroenterologist. The payment will be paid to the doctor. There is no payment for an interdisciplinary team, for a nursing care, for social work, for chaplain support. None of that is part of any payment guidelines set up by the government. Curative and palliative options are provided together. So curative treatments are expected to be part of palliative care. And because of the lack of reimbursement and guidelines, the creation of palliative programs really started inside hospitals. And hospitals became the main location. And the reason for that was hospitals saw the value of providing aggressive curative treatment and palliative care support to people. There was tremendous financial benefits to hospitals because people were on to palliative care, and that financial benefit came at reduced ICU usage and less medicines ordered and less aggressive use of labs. So hospitals were the main site. Since its creation, since hospitals have been involved, it's spread. It's spread to home health. Livingston provides home-based palliative services. It's spread into some skilled nursing facilities, and it's spread into offices. There are palliative-based offices in the country, but still hospitals are the main focus of where palliative care is provided in America. Here from 2000 forward is the percentage of US hospitals with palliative care programs. And it's now well over 85%. 85% of all US hospitals with 50 or more beds have a palliative care program. In Ventura County, the first palliative care program was set up at St. John's in Oxnard. Community Memorial has a palliative care program. Ventura County Medical Center has a palliative care program. Los Robles Hospital has a palliative care program. Simi Valley Hospital has a palliative care program. Ojai Hospital uses communities. Santa Paula Hospital uses VCMCs. So every acute hospital in Ventura County has a palliative care program. That palliative care program is designed to provide support to the patient and family while they're getting curative treatment. So the logic is you're getting your traditional medical care, and while you're getting that, as that illness becomes more serious, you add into palliative care, and at some point, hospice becomes appropriate. So you're getting your curative therapy for whatever your illness is. Palliative care is added on top of that until hospice becomes appropriate and you transition into hospice. That's the logic behind the structure of what palliative care is doing. Palliative care, very much like hospice, is a team. And who the hospitals are hiring is one palliative physician, typically, one specialty registered nurse, one social worker, and one chaplain. It's typically 4 people. That's the palliative care team inside most of our hospitals. Some of them use just the nurse with a consulting doctor coming in. Some pull obviously from their general social work and chaplain support, but the structure of palliative care, like the interdisciplinary team in hospice, is built around these individuals. The goal is that the palliative care team can clarify with you what's going on. You know, in the era of modern hospital care, you're dealing with hospitalists, and the hospitalist is very busy and going and doing 100 things. Palliative care is a wonderful opportunity to sit with a group of professionals who understand what your team is doing and can meet with you, the patient, and your family and clarify what's going on and how this treatment plan is designed to help you. And particular language that comes in is what is your goals of care. Now, if you go in to a hospital and you need your appendix out, they're not going to have you see a palliative provider. You're going to get your appendix out, you're going to go home. You go into a hospital to have elective hip surgery, they're not going to have you see a palliative person. You go in because your lungs are doing terrible. You go in because you have a terrible heart disease. You go in because you need an IV antibiotics as you have a bad cancer and you got a bad infection. Palliative care can get layered on top of that care in the hospital to help you and your family understand where you're at in your disease, review your goals of care, look at prognosis and options as you go along. So Palliative care really wants to help people understand what's happening. They want to create a good goal for you of what you want to try to make sure we manage symptoms and focus on what your quality of life goals are. That's palliative care and hospice care in America. That's the structure. So they're different. One is aggressive, looking at how to manage your curative treatment and palliative services at the same time. And one is aggressive comfort care as you're dying. So in summary, I hope we've talked about how dying is inevitable, but given modern medicine, you're going to be in this cycle of how to best treat you, and that there are two main programs, palliative care and hospice, that are structured around providing you care as these serious diseases get worse and as they become terminal. I hope that's as clear as mud. How can I help you? What questions do you have?